Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAMS-AIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAMS-AIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on 1st and 3rd Friday of every month from 3 p.m. onwards. The NAMS-AIIMS PGIMER CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medico CME is to help them to be more proficient in their profession. Each session will cover one or two topics followed by questions and answers. Thank you for your kind support.
Good afternoon and welcome everyone to the next session of AIIMS NAMS Navigate Medical Navigate CME program. So in the ongoing series of oral and dental health, this time the topic is very interesting. That is optimizing outcomes in aesthetic zone implantology, surgical and prosthetic synergy that has to be discussed today. And we have with us Dr. Gunjan ma'am. So since we all have been hearing and listening like in the previous lectures, the presentations regarding there are various birth defects, then there are a periodontal disease burden, then also there are traumatic tooth injury, there are also heavy tobacco use which is causing damage to the dentures, and also there are other systemic diseases which often push us for the need of implants. So now, since technology is there and there are a lot of other facilities including CBCT, CAD/CAM, so now there is a lot of advancement in the field of implantology. So today with us, we are fortunate to have the expert with us. So without causing further delay, I would like to request Professor Umesh Kapil sir for the welcome address. Sir is the Secretary of National Academy of Medical Sciences. Over to you, sir.
Good afternoon to all of you. My special welcome to all the participants who have come out to attend this important session. My welcome to Dr. Gunjan Pruthi, additional professor, who has very kindly agreed to be with us, and also Dr. O.P. Kharbanda sir, who has kindly agreed to coordinate this program. Navigate program is essentially a national virtual graduate training program. We started with it sometime in September 2023. The aim was that we will have the most eminent faculty in the medical colleges, in AIIMS, and in the Institute of National Importance to come and deliver a session, online session. And we will invite all the postgraduates, young faculty members, because they do come across the common topics which we have included in our Navigate program. This program is being conducted from 3 to 5 p.m. every first and third Friday. All lectures are being recorded and they are online transmitted on the YouTube. Plus, we are maintaining a virtual library in which all the presentations and the videos of the sessions are being kept. Now, if you look at the national scenario, we have about 120,000 students who pass out their MBBS course, and unfortunately, we do not have so many seats available for the post graduation. So there's a backlog of about 70 to 80,000 students who continue to be in the most peripheral primary health center, district level hospital, and they essentially do not have any opportunity to update their knowledge. So this Navigate program was thought that we will have their participation, will be able to update their knowledge. Hence, we started this program. With these few words, I would like to close over here, hand over to Dr. Jaswant Jangra to continue with the session. Thank you very much, Jaswant.
Thank you, sir. Thank you very much. So now I would like to request the technical team head, Mr. Raviji, sir, to please play a video message from President, National Academy of Medical Sciences, Dr. Digambar Behra. This is a video message which guides us about the ongoing Navigate Medico CME program.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various aims are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you very much. So, as Professor Umesh Kapil sir said, this ongoing series that all of us we are witnessing for past few months on oral and dental health. So, this series couldn't be possible without the chief coordinator of the series, Professor O.P. Kharbanda sir. Sir is a well-known personality, well-known figure in the medical and dental field, and I think there is no need to introduce sir, but for those, or maybe just I would say a few one, I would like to introduce sir briefly. Sir is currently serving as director at Orthodontics and Cleft Care Center. And sir is also Professor Emeritus and Council Member at National Academy of Medical Sciences, and has been former Chief at Center for Dental Education and Research, AIIMS New Delhi, and also CME at AIIMS New Delhi. So with this brief introduction, I would like to request Professor Kharbanda sir for his remark on the current series and today's topic which is being presented. Over to you, sir.
Thank you, Dr. Jangra, and thank you, Umesh Kapil sir. Indeed, I am grateful that National Academy has agreed to undertake the series on oral health, which is an absolute missing link between oral health and the systematic health as well. So in the holistic approach to health, oral health is quite integral, and it is often less discussed. So we chose topics on different aspects, and today's topic is related to implantology. The implantology has come a big way since the concept given by Brennemark on osseointegration, and it has revolutionized the way the oral rehabilitation we used to do. From acrylic dentures to titanium implants and suprastructures, we are able to now restore even the most difficult cases where the bone is very less and also bone is dissolved in adults who are even beyond 80 years of age, which was not possible before. At the same time, the teeth lost due to trauma in the front region require significant considerations when we plate implant, particularly with relation to aesthetics. Dr. Gunjan has worked with us at AIIMS as assistant professor, and then she moved to PGI Chandigarh, where she has continued her passion with the implantology. And we have chosen her for her known expertise and also speaking skills. With this introduction, I'm sure that this field of implantology and what she's going to cover in 1 hour will expose and introduce this new field to the listeners, particularly the critical aspects on material bone interface, the biological part of it, a little bit on perimplantitis, and also long-term implications. Thank you, Dr. Zanga, for giving me this opportunity to speak and introduce the subject to the audience.
Thank you, sir. Thank you very much, sir, for the remark. Now it's time to introduce the speaker of the day, Dr. Gunjan Pruthi ma'am. She is currently serving as additional professor in prosthodontics and oral implantology at Oral Health Science Center, PGIMER, Chandigarh. Ma'am has a huge teaching experience of over 17 years, and she has been honorably awarded fellow and clinical observership at prestigious Melbourne Dental School, Australia, and Royal College of London, UK. Ma'am has also completed advanced training in implantology at Osaka, Japan, and she has been fellow and member of various international and national societies. Uh, Ma'am has a huge H index of 13 and also I-10 index of 14. So this shows her research acumen. So with this brief introduction, now I would like to hand over the uh, dice to ma'am, and it's over to you, ma'am. We all are eager to hear to you, ma'am.
Thank you so much. So, can I start sharing my screen?
Sure, ma'am. Please.
Is my screen visible? No, right?
मैम आप इसको स्टॉप करके स्पेसिफिक स्लाइड का वो आएगा मैम, वहाँ पे करना जैसे वंस यू क्लिक स्टॉप स्क्रीन शेयर, उसमें फिर वो पीपीटी वाला पोर्शन आएगा, खाली उसी पे आप क्लिक कीजिए।
Just give me a minute.
हाँ, it's a
Dr. Gunjan, can I help you? If you can bring your cursor
maximize is
on the down. No, it was, you were okay. You were doing very good. Come back where you were before. आपका तो आ गया था बिल्कुल ठीक स्लाइड्स।
We apologize for the technical glitch, but we also thank all the participants for the patience. And I think within a few minutes, this will be resumed.
गुंजन क्या दिक्कत आ रही है? हेलो, because people are waiting, you know. हाँ गुंजन, हाँ नहीं नहीं नहीं, आपकी स्क्रीन हमें दिख रही है.
It's visible, ma'am. Now it's working.
Everything is working.
It is working
Yeah,
now.
Please start.
Just minimize this screen.
Yeah,
Yes.
yeah, right.
बिल्कुल
Okay.
ठीक है, आप शुरू हो जाइए.
Sorry, sir. Sorry, everyone.
No problem.
Just I'm used to of like Windows and desktop, and it is a MacBook. So thank you so much to everyone, especially Dr. O.P. Kharbanda sir, for and NAMS for giving me this opportunity today. So I'll straight away start because I've taken some time in setting up. So my presentation is about today about the interior zone implantology because that is my passion to work on. And I want to stress upon today about the synergy which is important between the surgical and the prosthetic principles. If a surgery is good, prosthetics is not good, it doesn't work that way. And if it is otherwise, like you want to give a good prosthesis to a patient, but the surgical outcome is not good, even that doesn't work. So there has to be a synergy between the surgical and the prosthetic principles in implantology, especially in the interior zone where aesthetics is very, very important. So we have been listening to this that bone sets the tone. So bone is obviously very important because if bone is present, only then we can place the implant, or we can grow the bone as well with the today's technology, recent craft materials and everything. But tissue is the issue. So why is tissue is the issue? Because you can grow the bone, but it is very, very difficult to grow back the soft tissue. So you have to take care of it in the beginning itself. And thirdly, I would say that pros is the boss. Hello. So I would say that pros is the boss. And why is that? Not just because that I am a prosthodontist, it's because that we always focus on the prosthesis driven implant planning. And all these factors work well in coherence if we go for a prosthesis driven or a restorative driven or aesthetic driven implant planning. That forms the foundation of all of the implantology. So this presentation, as everyone said, it is like focusing on the postgraduate students. So I have covered a lot of theoretical part, and I would also be showing some cases and then some key takeaway messages which everyone can incorporate into their day-to-day practice. So first is the etiology. Dr. Kharbanda has already told us that the most common etiology for an anterior tooth loss is trauma. But why? Because there are so many environmental factors such as sports injuries we see, especially in our country. No children whom we see in the playgrounds, they are wearing any kinds of mouth guards, they are not taking any protections. So this makes them more prone to the injuries, and especially when there is a situation like class 2 div 2 proclined anterior teeth, when they fall they are very much prone to get their anterior teeth fractured, and then because of a short profile, it can lead to a higher impact. Another problem in our country is low socioeconomic status. It's not just about the finances that they can't afford a treatment, but also the awareness about the right timing to approach an orthodontist, or right timing to visit a dentist as such, or as such realize that if you have proclined teeth or some malocclusion, then it can lead to some fatal consequences in the later stages of life. So all these things we know that are predisposing patients to trauma, and maxillary central incisors are the most frequent teeth we know that get fractured and get fractured, and then later on it becomes difficult when the patients come to us to salvage such teeth, and then we have to think implants as an option for those patients. So we see that most of the patients here are young patients. So why I have shown this age of the patient as such here? This is important because now you see the patient is just 16 or 22 years old, and we have to deliver them a processes which has to last and serve those patients for next how many years. So it is not the question of just 1 year or a 2 year survival. It is a question of at least 15 to 20 years survival in the patient's mouth. So we have to keep this in mind whenever we are trying to take up a patient for implant supported prosthesis, or as such any kind of rehabilitation. So other causes, we know that endodontic failures, internal or external root resorptions, and eventually the fracture of endodontically treated teeth along with periodontitis, this all can lead to loss of anterior teeth. And the consequences, they are just not physical trauma, like the one patient got an accident, okay, he will recover from that accident, but the consequences on their teeth on the later stages, especially when they don't report for an immediate treatment, that leads to fatal consequences like bone loss, the space mismanagement, the fracture of the teeth. Then there is severe tilting and malocclusion, which is hard to treat, and then eventually sometimes ankylosis as well. And when they come to us prosthetically, these situations become very challenging, like to cover up this huge missing space, and although just one central incisor is missing, or when there is a vertical bone loss as well. It is easy to manage a horizontal bone loss, but getting that vertical defect to a normal level, especially when there's a loss of keratinized tissue as well, it is very difficult for us. So let's see example that in this case it is a loss of two teeth, the central and the lateral. This was a young girl, and we see while planning of the case that the zenith of the two teeth, they are totally at a different level. There's a vertical bone loss, and if we try to place an implant that is going to be in the connector region, which is not actually recommended if we want to have good aesthetics, and then it is almost next to impossible that we can grow this amount of soft tissue or give a good papilla back to the patient. So these situations become very challenging, and then this girl, she was referred to me for implant placement, but I saw that her central incisor was ankylosed. Now, if it is not moved to a suitable position, how can I restore the aesthetics of the patient? I referred her for orthodontic treatment. They referred it back to me. I could not help the poor girl in a good way. So we know that speech, function, aesthetics are obviously affected whenever there is a loss of anterior teeth. But overall picture is that we have to take care of the psychological well-being of the patient. It is not easy for them to accept this much of a loss. This is a young boy who lost his front teeth. He came to us. We told him multiple times that without grafting, a lot of grafting would be required. A secondary donor site would be required in case we are if we have to make him suitable for implant placement. He went to a private dentist. He gave him a fixed dental prosthesis. He again came back to me, and he is psychologically so much tormented that he even tried to have some suicidal tendencies and locked himself inside, that till you don't get me my implants done, I'm not going to come out of the room. So the patients came to me insisting that somehow please help our child, and he made all kinds of excuses like a bad order, a bad taste, so that he could somehow convince us to give him implants. So major goals, we know that it is a prosthesis-driven implant position, good aesthetic outcome, and long-term survival and success, which I have stressed upon and I would be stressing throughout my presentation. So first visit is very important whenever a patient comes to us to set up the whole alignment of the treatment in future course. So we start with understanding the chief complaint of the patient. It is not just what the patient tells us, but it is what we interpret and we try to extract out of him, that actually what does he want from us. He would not say straight away, he might be using some other words, but we have to understand, because that decides what are the expectations of the patient from us. Then oral hygiene status at each visit has to be taken care of. We have to analyze the condition of the remaining teeth. What led to the tooth loss is very important to understand. Then soft tissue health is primary goal, and then understanding the medical history, because the patient is going to undergo a surgical procedure. And then parafunctional habit, it is a must to be checked, especially like bruxism or tongue thrusting habits, because if they go unnoticed, they can lead to straight away implant failures and devastating consequences. Then we have to know these are young patients, whether they are smokers or not, and have to be managed accordingly. And always patients have to be given all kind of treatment alternatives first before heading to a final treatment plan. So we start with the diagnostic wax-up, diagnostic impressions or intraoral scans, and then always do a diagnostic wax-up to tell yourself that what do you want and what you can achieve, and then for the discussion with the patient as well. Then the photographs, good quality photographs with all sort of coverage is very important for documentation, for legal things, and for comparison at different stages of the treatment. Whenever the patient comes to our chair, before touching the patient on that day for further treatment, always try to take a record of the patient on that day or the visit. Then radiographic examination, we know it is must. I'll be taking it further. And important thing is the financial status. So it is not like that if the patient doesn't have money or less money, we'll give him lesser number of implants or more number of implants. No, because see, this is a wife of a laborer who fell from the roof and lost her teeth, and she came to us that I want fixed teeth. But now to give her fixed teeth, the financial implications include at least 4 implants, the graft, the processes, the maintenance. So many things are required. So would she be able to pay for all of those things? No. So she has to be convinced for an alternative treatment care or whatever is better suited according to the financial status. But patient has to be clearly told in the beginning the amount, the timing, the cost of the treatment, when he has to pay and how much he has to pay, and he should be prepared and committed to that. Then time is important factor. Patients have heard about tooth in a single day. It is a very common thing these days, and patients come with very high expectations, but they don't realize the condition which they have come in which they have come to us. It is practically not possible to give implants in immediately or even in a month of like in a period of 3 months in such patients. It is going to be a very long journey, and so their expectations have to be brought down to reality, and they have to be explained that yes, the treatment is possible, but we have to patiently go with the flow of the time and go take the treatment as it comes. So coming to the radiographic assessment, intraoral periapical radiographs, they give us a lot of information, and that can be used to decide our initial treatment plan, because we can see that yes, all these teeth are non-salvageable now. So somehow we have to extract them and take them to a next level for rehabilitation. But our radiographs should be good. They should give us right information. They should not be misangulated. So we should take care that whenever we take a radiographs, they should be taken with a positioner. They help in the future comparisons. For example, in this case, this radiograph was done by the technician, and I placed the implant, and I was like, oh my God, is it too close to the adjacent teeth, or what have I done? But then when I took the radiograph myself with the help of a positioner, so this is the same patient with a good and well positioned implant. So this is very important that whatever we do, it should be using a good technology. Panoramic radiographs, because of the focal trough and all those things, anterior zone, they are not very good. But in case we want to evaluate the whole dentition as a whole for the patient, then yes, we can go for panoramic radiographs. But we should be careful about the magnification errors which are inherently present in the OPGs. And 3D radiographs like cone beam CTs, I would be discussing later in detail about their pros and cons. But one thing is here that if you want to measure the mesodistal distance between the two teeth, that is very important for our deciding of our implant dimensions, as well as to see like what is the inter-implant distance, what is the distance from the adjacent teeth. So we need to measure that inter-implant distance. But we have to be careful that that should not be done in a cone beam CT's panoramic view, because as you keep on zooming the image, this distance starts on changing. So this is not the exact way. You can do that on the diagnostic models, or sometimes with the help of a digital caliper in the patient's mouth as well, and then correlate with the angulation of roots in the radiographs. So overall, we have to now focus on the clinical examination. We have already done oral hygiene, given oral hygiene instructions. Now check for the maintenance, check for the soft tissue health, check for any further treatment required, and now particularly focus in the region in which you are going to work on. And that starts with the assessment of your gingival phenotype and pink and white aesthetic scores. So these pink and white aesthetic scores, they are given point to point how we measure them, and then we can keep them as a record. We can compare them like when we deliver the prosthesis, or we do some kind of a research on such patients. So these are objective criteria to analyze and plan your treatment. And this can be discussed with the patient as well in advance, so that they also know what is the possibility. So gingival phenotype, it is very important because it has to be thick to deliver good restorations, because they lead to less mucosal recession later on, lesser bone loss, and then they better disguise the different restorative materials. They can be checked with the probe transparency method using any kind of probe, but you should not miss upon checking that it has to be at least a medium or thick gingival phenotype when you take the patients for implant placement in aesthetic zones, especially when you're taking him for an immediate implant placement. So when your initial workup is done, you have to discuss the plan with the patient, with the family, with your team, because you might need the intervention of other members of the team as well. And then you silently move forward to detailed explanation and discussion with the patient. Informed consent should never be missed, and you explain the patient about the nature of the treatment, the alternative options, the risk benefits. Everything has to be explained in detail, and you have to be ready and patient to answer all the questions. I know sometimes they drive you crazy by asking those questions again and again, but that doesn't matter, because it will prevent any kind of frustration or loss of time and money in future for both of you, not just you, for the patient as well. So coming to the radiographic examination, earlier, the clinicians used to just take the intraoral periapical radiographs and place the implant. But now, cone beam CT, it has become so accessible, safe, easy option that no implant should be placed without a cone beam CT's detailed examination. It gives you all the information through various sections, be it a panoramic, axial, or sagittal sections, and then you focus on the area where you want to place the implant. So these sections tell you about the prognosis of the tooth, the condition of the root, the amount of buccal bone, the palatal bone, the amount of bone present apical to the root, or any kind of buccal undercuts. So you can analyze in all the sections whatever information you want to extract. So in this case, if you see the IOPA, you see that yes, there is a crown root fracture, there is a soft tissue inflammation, there is a little bit of periapical pathology. But still, you want to investigate further, and then you see in a CBCT the clear picture, whatever is going into the patient's mouth, and then you decide whether you want to go for an immediate implant. No, because there's a big periapical pathology. Maybe you can go for an early implant placement. So all these factors can be decided. Here only, you want to go for an orthodontic extrusion, you want to extract just a fragment, you want to go for a crown root fragment attachment. There are plenty of options. So this picture will make you everything crystal clear for you, that yes, this patient is a case for extraction and maybe an early implant placement, not an immediate implant placement. Similarly, we can see that there is a horizontal bone fracture which could not be seen on an IOPA, and then the cases of impacted teeth. You can't see the angulation and the position of the impacted teeth because they come in the pathway of your implant placement. So in this case, we had to extract the impacted canine first, graft the site, and wait for some time to make the patient suitable for implant placement. We can also appreciate the important landmarks which are present, and so that we just don't encroach the adjacent tooth or the landmarks. Then we can superimpose the intraoral scan files with the cone beam CT for our digital implant planning and fabrication of surgical guides. We can place the tooth to assess whether we can go for a screw retain processes, whether we need to undergo a bone augmentation procedure before we take the patient for implant placement, or with the implant placement, or we'll have to go for a cement retained processes. All these things can be decided right before touching the patient at your planning stage. Another important thing we have to consider is the root position. So we see that there are multiple root positions in the patient's mouth, and in case I want to go for an initial osteotomy in such positions, and if we have a thing that whenever we place an implant in a fresh extraction socket, the root tends to slip in the path of least resistance. And suppose if this is the path of the least resistance, definitely I'm going to perforate the labial cortical plate. So I have to plan according to the root position. So this article has also given us the guidelines. So which root position is suitable for which type of osteotomy, and we can plan our type of processes as well. And the literature shows that the class 2 type of root position, it is the most prevalent root position, and our study showed that this is the most difficult situation to handle. So we have to go for a guided surgery in case we want to place implants in type 2 sockets, or generally also if we want to place predictable implant placement in the interior zone, we consider different root positions, and we better rely on the guided surgeries rather than going for freehand placement. Another level, we took it to the fabric examination of the prefabricated provisionals as well. So is it also related to the type of the root position or the socket anatomy? So yes, it is related, because in type 2 root positions or the socket morphologies, the inaccuracies in the processes were also found to be the maximum. So we have to keep in mind these factors at a planning stage, or during the chairside adjustments we might need whenever we are going to deliver the prefabricated provisionals to the patients. So all these factors need to be kept in mind when we are placing implants. Now, another important thing is that we can nowadays take the facial scans as well. So we can superimpose these facial scans. We have a live, not just live, but a virtual patient in front of us now, and we have his intraoral scans, and we have everything with us, and we can plan the case and discuss it with the patient that now this is the final position and the final condition, and this is how we are going. So the workup is very important. The diagnosis and treatment planning needs the maximum time. The implant placement or the prosthesis fabrication, they are still easier. What is most difficult is the diagnosis and the treatment planning part, and actually we don't devote that much time to it whenever we are taking a patient for it. We just want to go ahead with the implant placement. So I would request that no, just plan the case, give time for the planning, and then move forward to whatever you are executing with a customized plan for each patient. No two patients are same. Every patient is different. And for that, we have to consider so many factors like the timing of implant placement. We have to decide whether we have to place the implant and graft it on the same time, or we have to do that in different set of appointments, whether we have to go for a bone driven implant. Usually we see that surgeons find a good bone and they place the implant, but then it is difficult to deliver a screw retained prosthesis, which is the need of the hour, and then we have to go for a cement retained prosthesis, which is not at all recommended. So we have to take care of these factors, and then we should know whatever we have planned, will we be able to achieve with a freehand surgery, or we need a guided surgery to execute that. We need to go for a flapless surgery, like in some cases if it is a good bone, a good like mandibular first molar region, okay, or for immediate implant placement where you can go for a atraumatic extraction, no other grafting procedure would be required, okay, you might go for a flapless, but you should have a professional ready with you. Or in most of the cases, we try to go for an open flap surgery because of good visibility and accessibility. So implant design is also very important. It's not just that one implant can fit into all situations. You have to think about the surface characteristics, thread geometries, type of implant, dimensions of the implant, which are suitable for a particular patient. And another important decision is like, if I don't have sufficient bone, I can just place a narrow diameter implant. But would you go for a narrow diameter implant in a central incisor region with a good width? How will you achieve the aesthetics? It is okay if you go for a lateral incisor region where the mesodistal dimensions or the space is less. But for a central incisor, I would prefer to go for a bone augmentation procedure, make a good bone bed, and then go for a regular platform implant. So we have to take care of all these factors. We have to decide what type of graft is required because there are a plethora of options like an autogenous graft which can be harvested from symphysis, tuberosity, ramus, iliac bone. We have to think what kind of graft and what size of graft do we need, or we just need a xenograft or a synthetic bone graft like an alloplast. So, or we are also using platelet rich fibrin these days. So situation based, we have to decide which graft material will be suitable for a particular type of patient. Then the loading we have to decide. Then the material of prosthesis. Usually we forget to think about the material of the prosthesis in the beginning, but you see there are plenty of options. It's an EMAX, it's a zirconia, it's a milled PMMA. So all these things we have to consider prior and discuss with the patient because cost also becomes an implication here. Then again about the screw retained versus cement retained processes, or whether our processes is going to be splinted or non-splinted. So overall, there are so many factors which need to be considered. It is not easy. So coming to the decision making between immediate, early or delayed implants. So what I do mean with that, it is based on a simple classification given by Dr. Bruiser, in which they say if you place the implant on the same day, then it is an immediate. Then if you wait for 4 to 8 weeks, some kind of soft tissue healing occurs, so it is an early implant placement. Another, if you wait for 12 to 16 weeks, then partial bone healing has also occurred, and type 4 or late implant placement when you wait for more than 6 months. So all the options, they do have some pros and cons. Most importantly, in a type 1 placement, patient doesn't have to undergo two surgeries because we place and extract in the same time, but it is a very, very technique sensitive procedure based on very stringent selection criteria. And in case the patient has some local pathology, like I said earlier, we can just remove that pathology, clean that area, let the tissues heal a bit. It becomes a bit easier for us to place the implant. But what if we want to tell the patient that you come to us after 6 months? Would the patient agree for that? Because it is an anterior tooth. Sometimes patients do report at the later stage, but once if the patient reports right away after extraction, we can't tell them that come after 6 months because we know what is going to happen with the bone. So much of loss of weight and height, and it is so difficult to manage the loss of height. This is the example. The RPT was given to the patient, and after 3 months, this amount of bone loss he has already suffered. So this, we don't want to land in such kind of situations. And now till now, I was talking only about the protocol for the implant placement. Now we have multiple protocols to decide for the loading as well, and not just one and two. Now these overall compile to be 12 scenarios from which we have to decide which is the best suited for the patient who has come to us. So it is a difficult decision. So we have to find the solution, maybe based on our experience, or we delve into the literature. So the current literature is huge. So I've just chalked out 2-3 articles on that. And so generally, this is an article in 2019 which says that they achieved most excellent results with the late implantation protocol in terms of aesthetics. But the most unacceptable results were also with the delayed implantation. So they concluded that even with the immediate implant placement, yes, the results were good, but the safest protocol is the early implant placement. And whatever you decide, you have to make sure that soft tissue has to be good at least more than equal to 3 millimeters to have a long term good outcome. This is a recent network meta-analysis in which they have concluded that immediate implant placement and loading, they perform best in pink and white aesthetics, and obviously patient satisfaction is like most welcoming in this sense because they get their teeth as early as possible. But for immediate implant placement, as I said earlier, there has to be a proper case selection. Otherwise, we have to go for an early implant placement or a delayed implant placement. So, Dr. Thoma, they have concluded somehow in the recent article in 2026 that there's no universal rule that applies for the selection of which protocol you are going to use for a particular patient. There's just one basic principle that it should be as early but as safely possible, because now we have multiple new technologies available. So you just have to keep in mind that it has to be as safe as possible for the patient, and if it is good, that you can do the treatment as soon as possible. So the key, finally, just to sum up whatever I have discussed till now, the key to success is based on the meticulous case selection, and that has to be based on the sufficient availability of sufficient bone volume, buccal bone thickness, which has to be more than 1.5 millimeters, then the keratinized mucosa, and an optimal three-dimensional implant position. There's a very, very high tendency to place facially malpositioned implants in the anterior zone, and that destroys everything, the bone and the tissue. So you have to have that clinical expertise, and to avoid such misangulations, you have to go for a guided implant placement, and your patient has to be compliant. So now I'll just take you through the journey of few patients. This is a patient who reported at 8 years of age to our center and managed by the periodontist team because he got his central incisor avulsed at that stage. So he went through the journey of all the treatments like root canal treatment, calcium hydroxide dressings, and then revascularization, and finally he got his central incisor, healthy central incisor at that time. But many years later, the patient came to us with a complicated crown root fracture. And we can see the amount of bone loss which is present here. So he was having just not just a fractured tooth with an internal or external resorption, but he also had a huge cyst. So first I had to get that cyst enucleated from the oral surgeon, but that led to such a huge defect that we had to first go for a guided bone regeneration. So this is the staged approach I was talking about, that first we go for a bone augmentation procedure, leave the patient for a few months, and then take the patient again when his bone is suitable for implant placement. These are the subsequent scans which we can appreciate the cyst, the loss of bone, and then regrowing the bone in that region. And then we plan the case for implant placement. And this is the when I took the patient for implant, still the bone was deficient, so I covered it with an autogenous bone chips. And finally the patient was ready for the rehabilitation. I took a digital scan. I also take subsequent scans as a record so that I can do the volumetric analysis to check the amount of loss of bone with time or the gain of bone with time in some situations. So this is the whole summary. As it is a big case, he had to went through so many procedures. It took almost like more than a year to make him suitable for implant placement and finally deliver him the prosthesis. So this is the boy from his young age to now he's a boy and studying in an engineering college, but he's very confident now. Another case, I specifically put this case so to show that we need an orthodontic intervention sometimes when the patients they suffer with an injury at the early stages of their life, and then if they don't take any treatment at that stage, this is the condition of their dentition at a later stage, and then it becomes impossible without undertaking any orthodontic treatment. This girl is a lawyer and she was very particular about her aesthetics. So our orthodontist, he always made sure to put in riding pontic during his orthodontic treatment, and then he referred to me for the implant placement after orthodontic correction. But by that time, the bone was totally lost in this region. There can be alternative treatment options as well, but I took the patient for again a guided bone regeneration so that I could get some good bone where I could place the implant, and this is post implant, but always the patient was aesthetically rehabilitated with the riding pointing till this stage. Now, important lesson here, what I wanted to give was message was that this is the final crown of the patient, but there is so much of shade discrepancy, and this happened because I took the shade of the patient while she was having her brackets on. So whenever there is an orthodontic patient, it is always good that first let the patient get her debonding done, all the cleanups done, and then you take the shade so that there is not such a huge discrepancy. Along with that, the gingival zenith was not matching to the contralateral tooth. So I did some contouring with the help of the laser, contoured the temporary restoration multiple times until the time I could achieve exactly matching zenith with the adjacent tooth. I restored the patient to give her the final crown. And this is over the years how she looked, and finally she is happy with the final outcome. And these are the sequential radiographs. Another case, just to show that sometimes the mesodistal space is less. We cannot go for two implants, or if we go, they'll be too close that the bone will be lost between the two implants. So we can also think of an option like a cantilever prosthesis. So this patient also had a history of trauma, but he reported later, and it is the rarest of the rarest phenomena when I can see such kind of a good bone available in the anterior region. So it was easy to go for a first I did the workup, and then it was a freehand implant placement. I make this kind of a stent to ensure the emergence of my implant, which has to be in the cingulum area, and to prevent a facially malpositioned implant. I covered the implant with some autogenous bone chips, and then this is after the healing. After 3 months, I prepared, got the root canal treated one and prepared it for a crown. And this is the final restoration, a screw retained restoration, and a very good aesthetics which I could achieve in this case. Another case of a delayed implant where I want to show the importance of the soft tissue in this case. So this patient had a defect. I achieved the primary stability while placing the implant, but I had to cover it with some bone. I did not place autogenous bone chips at that time, but I covered it with the xenograft and a membrane. So later on, the patient reported with a pustule in the soft tissue, and that was a recurrent pustule. Every time I used to clean it up, give her a Metex gel, but again it used to emerge back. So I had to refer the patient to the periodontist, where they found that the threads of the implants were exposed. So they again covered it with the graft material and covered it with the layers of multiple layers of PRF membranes, the platelet-rich fibrin, and then closed it nicely. Then after a few months, the healing was good. So I then could go ahead with the prosthesis fabrication, scan her, and give her a good crown. Since this patient is still on follow-up, because I think there might be a need of further soft tissue grafting in such cases, and that is what I wanted to tell you, that whenever there is a need, there are plethora of options available for soft tissue grafting as well. If you can't do it yourself, you take help of the other members of the team, and always consider if you need some soft tissue grafting in such patients, rather than repenting later on, making them patients suffer with the recessions and all those things. So coming to the immediate implants, I'll run through the cases quickly now maybe. So this is a patient who had two anterior teeth which were completely mobile. So I took this patient for immediate implant placement, and augmented the site with xenograft and platelet-rich fibrin. We need to always cover the buccal gap around the implants, and these are the final processes which were given to the patient. And patient, he had a he was very much involved in the speaking activity, so I did not think of other options in this case, and I went ahead because he had a thick tissue at least available. So that is why I went ahead with the immediate implant placement. Another case with a guided implant placement, where I had the surgical guide and a prefabricated provisional which matched the original crown of the patient as closely as possible. So it was delivered on the same day of surgery. Then this is the post-operative CBCT. Then we take a 4-step scan to duplicate the anatomy of the provisional crowns which we have achieved over the time. and then we try to duplicate it into the patient's final crown, and this is the final prosthesis which was given to the patient. But still, I would like to highlight here, this is just 2 years I have given the prosthesis to the patient. But we know that recession of mid-facial mucosa, it is a very, very big risk with type 1 placement, and it starts happening after 3 years of implant placement mostly. So we have to think in prior that whether we need to do any kind of a soft tissue augmentation procedure or not. And the other ways are like we go for a flapless surgery so that we maintain the blood supply around the implant, optimal buccolingual implant positioning, always fill the buccal gap with a bone filler material, or we can use for concomitant use of we can go for concomitant use of connective tissue grafts, as I said earlier. So this is about the optimal implant positioning, that our implant has to be 1 to 2 millimeters palatal if we join the incisal edges of the adjacent teeth. Generally, we see that the implants are placed somewhere here. So that is not the right way. It is always have to be in the palatal position. Then it has to be in a safe zone without encroaching the adjacent teeth, and it has to be submerged at least 2 to 3 millimeters into the bone as compared to your interdental bone. And all these things depend upon your surgical technique and experience. So you can go for guided surgeries to achieve whatever you want. Another important factor, it is the buccal gap around the implant. We call it as jumping distance. So it always has to be bigger. So what you can do, people tend to take as bigger size of the implant in terms of width, but that is not recommended, because we think wider the implant would be, more implant stability we will achieve. But no, go for a narrower implant and maintain this gap and graft this gap always. You will always have a better outcome in terms of your soft tissue as well as in terms of your bone around the implant. Narrower buccal gaps less than 2 millimeters, they really need to bone resorption. You find the whole labial bone missing within just 6 months of span of time. So that is not to be done. So I also did a study. It's an ICMR funded project in which we use different type of graft material. So use any type of graft material which is suitable and available and you are comfortable working with, but always graft the peri-implant gap. And this is about the soft tissue around our provisionals. We need to understand the importance of the anatomy, that there are, in just this amount of soft tissue, we have different types of attachments, different types of zones, our junctional epithelium, our connective tissue, and everything is important. That it is important for our bone, it is important for our connective tissue, it is important for our biological well-being. So all these things have to be understood and then kept in mind while you're contouring your temporary and final restorations. So what if such kind of possibilities are not available and ideal situations are not available? As I told earlier, that we go for early implant placement. So one case of an early implant placement where the patient came to me with such kind of condition of teeth and there was so much of inflammation of soft tissue. So how can I go for an immediate implant placement in this case? The girl was young, she wanted an early treatment, but no, I told her that I will first extract the teeth, because in CBCT the bone was also missing. So I convinced her for an immediate implant for an early implant placement. I got her teeth extracted and I convinced her. The first thing I told her, you'll never be without teeth. So patient think, what will I do if my tooth is extracted? It is a front tooth. How would I go to the work tomorrow? How will I go to school or college tomorrow? So I just tell him then the first thing, you will never be without a teeth till you are under my treatment. So before our extraction, I just make this S6 retainer, and on the day of the extraction, you can see she just got her extractions done. I just put some pink composite here to give a good aesthetics to my retainer, and she was with the teeth always whenever she was under my treatment. So I went for a guided surgery because I knew that this is a very difficult case. So as you can see that the drills were almost out of the bone, so I just placed the implants, covered them again with the bone graft material, which was a mix of autogenous and xenograft, covered it with a membrane and have sutured, and the patient is now in a healing stage where the tissues have healed so nicely along with some pontic side development going on. Another case, usually we go for an early implant placement and late loading. But in this case, since it was a premolar, there's plenty of bone available to give you primary stability. So again, I extracted the tooth, told the patient to wait for some time, gave her an immediate provisional on the same day with a free hand surgery, no guided surgery. And this is the final restoration which I could give it to her. This is the final restoration. So what if we can't even go for an early implant placement? Then the option which is left is alveolar ridge preservation. So whatever is there, we have to preserve it, because in this case there was total bone loss, the external bone resorption, there's internal resorption, external resorption, and the bone was totally missing. So it was not possible even to go for an early implant placement with simultaneous bone augmentation. So in this case, I convinced the patient that we'll extract the tooth, we'll graft the site, we'll wait for some time. These are the decortications which we do so that the blood supply is maintained and the graft material is accepted by the bone. So this is how we proceeded. And this is a patient earlier when she reported to me, and this is after 5 months with such a good bone, and I have to take this patient for implant placement in next 3-4 days. So just one thing is left, that is the choice between cement and screw retained processes. I have always stressed that it has to be a screw retained crown. And why I'm saying so, that if we don't give a screw retained processes, we just screw the life of the patient as such. In this case, this patient had gone but taken this processes from somewhere else, and she reported to us with such kind of implant placement. And for the women, they were all cement retained processes, and taking them out was a big nightmare, not just for us, I think even for the patient. And we didn't know which implant system was it, but somehow we were able to remove the implants as well. And see the amount of bone loss she had to suffer because of this kind of a treatment being delivered to her. She's just 23, and then because she could not pay much again and again, so I just designed my kind of a surgical guide so that I don't go off the angle. And this is what I could deliver her after the implant placement, and finally she is in a good uh, shape. Another thing is that sometimes we don't have to think about just the implant placement, we have to think for the alternative treatment as well. This patient came with a request that please put immediate implants. In my case, I know about the immediate implants because he was a lawyer and a young patient, and he had no financial constraints. But I told her, no, we'll first try the alternative treatment options in you, and then only if it is required, you will be taken up for the implant. So these are just the provisional crowns at this stage, and he's so happy with the aesthetics and that he now is okay to go for the posted retained crowns or retained crowns, and he doesn't want implants. And sometimes it is really the best solution to say no in such situations, that whatever it may be, we will not over engineer and we will not go for implant placement in such situations. And we have to tell the patient about the reality and about the alternative treatment options. So again, I would stress upon the fact that long-term success should be the goal of our treatment. It will take time, but it is okay to go slow, but you have to go in the right direction. So finally, some take-home messages: that stringent patient selection is very important. We have to go for a thorough hard and soft tissue assessment. Alveolar ridge preservation, we see that it is always helpful whenever a patient with an anterior tooth loss or with a poor prognosis comes to us. We should give them an option of alveolar ridge preservation rather than sending them for extraction and then taking them for grafting and then taking for implant. It just adds to the time of the treatment, and no single graft material is the best or sufficient. So we have to understand their chemistry and mode of action, like which material is osteoconductive, which is osteoinductive. And so we have to mix them so that we maintain the space with the low substitution graft materials, and we try to grow some bone with some faster acting materials so that we get our bone bed ready quickly for implant placement in future. So I've told it multiple times that guided implant placement in anterior zone is very, very important. We know some surgeons are very skillful, but still, if you want to have that screw retained prosthesis, which is the need, that is really facilitated by guided implant placement, addition of just 4-5,000 rupees, but it adds to the prognosis of at least 5-10 years. So that is, I think, much more better option. Then, as I said, we have to maintain the buccal gap. We don't have to encroach the buccal bone. We have to maintain that space between them. So otherwise, that bundle bone will go away within a few weeks. So for that, it is important to have a 3D implant position in a perfect place. Then to retain prosthesis always, and the importance of multidisciplinary team cannot be negated. If you know something, do it. If you don't know it, refer the patient to a specialist, get it done, or do it together, learn it, and then you try it. But don't make the patient's guinea pig by doing whatever you want to do. So always complete your checklist. It's better because then you can prevent the complications. It's better that you execute your whatever you have planned, because this region is very, very sensitive zone. So thank you so much to NANS, Dr. Umesh Kapil sir, Dr. O.P. Kharbanda sir, who has given me this opportunity today to share my knowledge with everyone, my mentors, family, and the patients who trust me with the kind of treatment I explain to them, and they get ready to get that treatment from me. I try to deliver my best, but still there is lots to learn, and I'm still trying to give them the best. This is my team from oral surgery, orthodontics, my senior resident, and these are my dear residents who are helping me through and out in my surgeries, preparation of cases, the documentation of cases. So I'm really, really grateful to them. Thank you so much.
Thank you very much, ma'am, for the excellent presentation and the lecture. Ma'am, before proceeding, I would like to again remind the participants just to write or type the doubts or queries in the chat box of the Zoom so that we can see and we can convey the question to ma'am. But before we begin this question and answer session, one doubt that I have my own as a layman. So, like, majority of the people, they do undergo extraction, tooth extraction. And you mentioned that there are various factors responsible for the success of the implant, like bone volume, gingival mucosa, and many things. But you also mentioned that the key thing is early implant. So often we are advised by the dental surgeon to take a gap after extraction, like a minimum gap is needed to go for the implant, and also there should be no much delay so that it can be successfully done. So what's the ideal period after extraction, ma'am, for any implant?
So it depends and it varies from case to case. As I said, that if a patient has to undergo an extraction because of some reason, so like if it is a case of trauma or some other problem, and if I see and examine the patient and I find that everything is good, like the soft tissue, the available bone, and then the other factors as well, whether the patient will come for timely follow-up, whether patient will maintain the oral hygiene or not, whether the patient will be able to pay for whatever treatment we are advising to him, whether I said like I'll be able to maintain that gap, and most importantly, in most of the patients, what we see that the labial bone, the front bone around the tooth, that is missing. And if that is missing, it becomes very difficult to regenerate that bone. So if it is an ideal scenario, I will tell the patient, especially in private practice, you can't let the patient go away without the treatment. He'll knock the next door and get it done. So in the government institute, at least we have that genuineness in us that we will advise the patient whatever is right for the patient. So we'll tell them that it's okay. Earlier, I also used to think myself that if I tell the patient, no, I can't go for an immediate implant placement, they will think that, okay, we'll get it from someone else. That doctor advised me this, and this patient will run away from me. And now I understand. I explain them in the very first day, on the first day, 1 साल लगेगा पूरा ट्रीटमेंट होने में, सामने का दांत है, अब आप देख लो 1 साल वर्सेस आपकी पूरी जिंदगी, जल्दी करोगे तो आज के लिए ठीक होगा, 2 साल बाद लौट के वापस आओगे, then I will not do anything and I might not be able to do anything. So जो whatever is suitable and best at that point of time, considering all the factors, that is why now I have come to the option of early implant placement, क्योंकि literature भी वही कहता है and even I feel the same. My experience now, all my cases are early implant placement, because now I have a safe zone to play with. I have a very good soft tissue. I have like a good amount of at least some native bone which can be used for making or regeneration of the further bone around the implant. I can take some bone chips from the adjacent sides. So I advise my patients accordingly. Each case is different. It's not that immediate implant is not possible. It is possible in many of the cases, especially young patients are very good candidates because their bone, their response is very good. So I can go for those situations. Sometimes patients just insist on that कि हमें जल्दी से जल्दी ट्रीटमेंट चाहिए चाहे कुछ भी हो जाए. Then sometimes we have to consider, like one patient I showed you, he was referred to me by my HOD that he is a speaker. He has to speak every day. So I use that option in his case. But sometimes we have to weigh all the pros and cons.
Right, ma'am. Thank you, ma'am. Linking the previous question, there is another doubt in the chat box. Since you mentioned that young age is a good prognostic factor, so the one of the participants, they just want to ask about the prognosis or success rate of implant, mainly in elderly, and that too with many medical comorbidities like hypertension or diabetes mellitus.
So nothing is an absolute contraindication these days, be it a blood pressure or a diabetes. For blood pressure, I would say if the patient is on medication, if even he's maintaining like 140/90, we do take the patient for surgery. We just make sure that he has taken his medication on the day of the surgery. He has not missed on his dose, and then maybe on such in these patients, I would like to go for a flapless where we don't raise a big flap. I will be conservative in my procedures because one main thing I have to consider is that it's no risk of bleeding after the surgery. So as such, hypertension is not very difficult to handle. We just have to be cautious. And for diabetes, there are specific guidelines. For that, we consider the most important factor, that is his HbA1c levels. So that HbA1c levels, they tell us about the sugar levels of the patient in the last 3 months. So if the patient is in a pre-diabetic or just diabetic, like if his HbA1c is less than 7, we take the patient for the surgery. What is affected in diabetic patients is their healing. So sometimes there is a delayed healing and there are more chances of infection. So we keep them under a good and give them an antibiotic prophylaxis. Like before the procedure, we give them antibiotics, and then we take the patient for the surgery. We tell them to maintain their sugar levels and get them checked every 3 months. And so it is not a very big deal. Age is not at all a number, or not at all a factor these days. Like Dr. Kharbanda also told that we can place an implant in a patient even if he's 80 years old. So what depends is the amount of bone available and his overall general health. If he is not medically compromised, even if he is like a cardiac patient, or if he's a diabetic, if he's a hypertensive, we have measures to take care of all those things. We need to be much more cautious in them. We cannot go over aggressive in them. If any other alternative treatment can serve their purpose, like to all my patients, I give a first option of a denture, especially if they're old. That if you can eat with the denture, if your looks are good with the denture, if it is like so conservative and non-invasive, you wear it during the day, you remove it in the night, you are very safe and happy and all your things are solved, then first try a denture. Why not? Then if there is a scenario that okay, this denture is not serving you, it is not helping you, anytime you can come back to me. I plan your case for implants if it is suitable. Sometimes patients don't even come back because they say that we are happy and comfortable with the denture. Now we don't want any discomfort of a surgery. It's a big financial liability. So they are happy with that. So it is how we deal with a particular patient and a particular scenario.
Again, continuing with the previous question. So, uh, like uh, if one person is now wearing dentures and their query is if they delay their implant time, if wearing denture, if it delays implant time, so would it affect the prognosis of implant which is done after a prolonged use of denture?
Yes, yes, because with time, definitely there is a bone resorption. That means their bone levels will fall down in the terms of weight, height, especially in the upper arch, like in the maxillary region, the sinus floor that keeps on coming down. Patient don't even realize that thing. They come after many years, and by the time their sinus has come so much down that we are not able to straight away place implants in that. So there's another question in the chat box I can see that says that what is the minimum length required in the posterior teeth implant. So nowadays even a 6 mm implant is available. So if we have a
Right.
good width, we can go for even a 6 mm implant, or we can safely go for sinus lift surgeries as well if the patient's health allows. So there's a lot of improvement in technology and options. We can deliver anything which is best suited for the patient. But yes,
Right.
timely follow up and timely examination is important. That is why we say that you have to pay regular visits to your dentist so that you've not lost it to that level that now it cannot be compensated for now.
Right, ma'am. Right, ma'am. Thank you, ma'am. There is another question, ma'am. This is regarding a case of deficient labial bone in anterior maxilla. So the doubt is that should priority be given to the prosthetically driven implant placement with augmentation procedure, or to preserve the existing labial plate by compromising implant position within the available bone. So,
Yes, so that is what I said. This is a very, very common thing. So surgeon sees the bone, they go for a bone-driven implant placement, and then it becomes very risky for a later stage in terms of prognosis. Because anyways, if your prosthesis and implant are not in alignment and they just like don't have a very good prognosis. So I believe, and I have tried it myself, that your implant has to be processes driven. It has to be a screw retained processes. You have to augment the bone. Doesn't matter. Don't go with the anger, the current bone, but try to regenerate and then go for a processes driven approach, because the screw retained processes has got multiple advantages. Cement retained processes we usually don't recommend, because if you go with the bone, then it will have to be cement retained processes, or you'll have to go for some other options are always available, like an angle screw channel abutments, and so many things are there, but they're not easily available with us. So I try to stick to the concept that we have to go for a processes driven treatment. It is much more difficult, much more taxing. We need much more experience, much more skills, but we have to do that.
right, ma'am. Another input was given by, I think, sir, Umesh sir. Okay, so ma'am, your comment on artificial bone in orthodontics. I think this is the case, sir. Am I right or?
Yes, yes, you're right. Because sometimes they say if you don't have a bone, we'll put up some artificial bone and come after some time, we'll put a implant on in your place. So, what is this artificial bone, madam?
So, artificial bone means that we have a substitute for our natural bone. So, we cannot grow the natural bone as such, but we need some materials which we put on the native bone of the patient. They induce further bone formation. They have some mesenchymal cells, I don't know how to say in a layman language, but they have some cells which have the ability to induce further bone formation in the patient. So when we place on the patient's native bone, they try to grow that bone in the patient's otherwise the bone which is present. So with time the bone starts forming, and then we are able to place implants in those patients.
So, is
Especially,
it a normal
yes, sir. Yes,
intervention?
sir. It is. It is. I all my cases which I have shown, sir. I have placed the artificial bone substitutes, which are these bones are derived from sometimes the bone of a, like we call it as a bovine or porcine, from the cow bone or a pig bone. Then they undergo a lot of treatment, like they are demineralized, they are freeze dried, and they are made suitable to be placed in a patient's mouth. Then those bone have the potential to start new bone formation in the patients.
Thank you very much, ma'am. Thanks a lot.
Thank you, sir.
Yeah, Dr. Jaswant.
Sir, there is another question by Dr. Rishika. How do prosthodontically manage a deeply placed implant in the anterior maxilla?
So I don't know exactly what is meant by deeply placed implants. Maybe like either the soft tissue thickness is more, or you have placed the implants really submerged in the bone. So what you can do is you can customize your abutments. You cannot like orthodontically bring the implants out. There are actually case reports in which patients have tried to play around with the bone and orthodontically extrude them or align them again, but I don't know how is that possible. But yes, then you have to manage them prosthetically. You can use the abutments with the longer collar height. You can use multi-unit abutments, and over that you can customize your processes. So basically, you'll have to go for customized abutments.
Right. Thank you, ma'am. Thank you very much for the interesting discussion, ma'am. So now we have Professor O.P. Kharbanda with us. So, sir, any remarks or comment on the
My remark
character?
is that it is very beautifully given with case studies. But I wish to tell you that the field of implantology is still growing. And every day we have new modifications of the implant. So, for example, when there are complete resorption of the ridges in elderly people, we have implants called basal implants, which are placed not on the alveolar ridge, but directly into the zygoma and also into the deep into the ramus. So these kind of things are coming, but mind it, the higher the sophisticated the equipment, sophisticated is the maintenance, and the higher is the cost. So, uh, so the implant is a solution, but it requires heavy maintenance on the part of patient because around the implant, like we have got periodontitis in the root, around the implant we get periimplantitis. So implant also fail. People forget that once you place an implant, it's a permanent solution. No, it requires maintenance. It requires hygiene around the implant, collar around the neck, so that the bone resorption is not progressed. But this is one of the most advanced applications in dentistry which has happened. It has changed many things for many patients. It has benefited millions of people. But at the same time, the anything which is artificial is artificial. It is a substitute. So the message is don't let the natural dentition lost. So prevention
It's 4:30.
is the best option.
Yes, sir.
And I think I should thank Dr. Gunjan for beautiful lecture.
Thank you so much, sir, for giving me this platform and opportunity. I'm happy to
Uh,
share my knowledge.
and we had participants from all over, so it speaks that how many people are interested in this.
So there's this
From just
one more,
last question,
yeah, one
which
more
is
question which I can see is that what about position of implants in the growing children? So more than like position of the implant, it is important that what is the age of the child when we are thinking of placing an implant, and we can place implant even in a 5 to 6 year old children, like if it is a medically compromised situation like an ectodermal dysplasia or something, because that is like much more important to maintain his social confidence and everything. And there are case reports which show that they have been successful in those patients. And if you are thinking about placing an implant, like I would go for an implant in a 16 to 17-year-old person as child as well. The only issue with the implant is that it becomes the crown you which should deliver over the implant, because it is still in a growing stage. So the crown comes in an infra-occlusion position with time. So you have to assess the risk and the benefit. If it is really mandatory to place the implant, there is no other option. You place the implant, you can temporize for some time, or you place a definitive screw retain restoration and explain to the patient that you might need a change of prosthesis after a 1 year or a 2 year period, like with time. Then the crown can be simply changed to a new crown with the matching of the occlusal level of the crown with the adjacent teeth. So that is to be kept in mind and explained to the patient beforehand. Otherwise, I don't think it's an issue, because same thing is there again, like loss of a front tooth, and the child would not feel much confident. If we give him a denture at that stage, he might not be comfortable. So, and another thing is, if we don't place the implant, then whatever bone is present, that will also be lost with time. So at least you go for a bone preservation procedure at that time and give him a retainer or something. Or you can also think about I forgot what I was saying, like you just have to preserve the bone. And another thing is, sometimes we can just preserve the root, let it go by a replacement resorption. It will keep on resolving with time, and at least it will maintain the bone at that place, and then later on it will be possible to go for an implant procedure. If we extract the tooth, we don't do anything, then the child comes to us and there is nothing available there, and then we have to subject him to the grafting procedures, and then it takes a long journey again. I hope I've
Right.
answered.
Thank you, ma'am. Thank you very much for the answers. Like, I think all the participants, they are happy to get their doubts solved. So now I think if there are no more questions, so we can proceed for the vote of thanks. So I would like to request Professor Umesh Kapil sir for the vote of thanks. So,
Thank you, Dr. Jaswant, for conducting this session such a meticulously. Everybody enjoyed, and there are about 200 people who have joined on YouTube. That's a very positive sign. The people are very keen to know about implants and their success rate. NAMS is most grateful to you, to Dr. Pruthi, Dr. O.P. Kharbanda, and all the participants who have joined this program. And we hope that we have another sessions in the field of oral health and dental sciences. Please join and get benefited. We are maintaining a virtual library of all the lectures in which all the PPTs and the video presentations are being uploaded. You may access them whenever you feel like, and you may ask any questions. You can put down to a mail to NAMS. We will love to get it clarified from Dr. Kharbanda and Dr. Gunjan and revert back to you. With these few words, thank you very, very much, and most grateful to you, Dr. Gunjan, again. Thanks a lot. Namaskar.
Thank you so much, sir. Thanks.
thank you, sir. So with your permission, we can mark the closing of the session.
I'm sorry
Thank you,
for
sir.
the initial technical hitch again.
वो याद ही नहीं किसी को अभी
Sorry.
Thank you, ma'am.